So good afternoon. My name is Chelsea Daigle and I'm a fourth year pharmacy student at Sanford University. I'm currently on rotation with Dr. Patrick Newman in the NICU, and today I'm going to be talking about respiratory syncytial virus or RSV. RSV is a single-stranded RNA enveloped virus. It's a type of pneumovirus. The way it works is a fusion protein in the glycoprotein attached to the human host cell. The virus is spread through respiratory secretions and can live on hard surfaces for many hours, making it easily transmittable. RSV has an incubation period of approximately 5 days, and people that have RSV can be contagious from anywhere to 3 to 8 days. RSV can cause an upper respiratory tract infection that looks much like a cold. You can see signs like cough and low-grade fever. It gets more serious when the infection moves down to the lower respiratory tract and can involve bronchiolitis or pneumonia. These children will present with wheezing or tachypnea. It is said that by 2 years old, all children will have had RSV in varying severities or symptoms. Statistics show that there are about 2.1 million outpatient visits from children less than 5 and 58,000 hospitalizations each year. RSV season is typically from December to March, and that's when the highest infection rates normally occur. It is important to note that Florida has an earlier seasonal onset with a longer duration of July through February. The CDC has a reporting and surveillance system that keeps updated data of RSV trends. This table that's on this slide here is shown on the CDC website. As you probably know, last year there wasn't much of an RSV season, and you can see that there is no peak in the middle of the chart. It is proposed that this may have been due to masking and social distancing during that time. Neonates that are born prematurely are at an increased risk because they may have not gotten all of their mother's antibodies. It is extremely important that we use caution and proper sanitation techniques around this high-risk group. Palivizumab, or better known as Synagis, is a recombinant humanized monoclonal antibody. It was FDA approved in 1998 for prophylactic use in high-risk children against RSV. The mechanism of action of Synagis is it binds to the F protein on the viral envelope and blocks fusion to the host cell. Dosing for Synagis is a monthly 15 milligram per kilogram IM injection that is typically administered in the thigh. The first dose is administered prior to the start of RSV season and each month after that for a total of 5 months. Because of the abnormal RSV season that we had this year, Synagis is being prophylactically used right now. So when do we use Synagis and who do we administer it to? It should be used in all of the following situations. In neonates who are born with a low gestational age of 29 weeks or less, in preterm infants with BPD, which is defined as birth gestation age less than 32 weeks and require greater than 21% oxygen for at least 28 days, in infants in their first year of life with a congenital heart disease. Following the previous slide, it should also be used in children in their second year of life with chronic lung disease who require medical intervention such as supplemental oxygen, corticosteroids, or diuretics. In children younger than 24 months who are immunocompromised. In Alaskan Natives and American Indian population who reside in remote locations and have limited access to hospitals. And in children in their first year of life and have pulmonary abnormalities or neuromuscular disease that impairs them the ability to clear their airway. RSV is the most common cause of bronchiolitis and pneumonia in children less than 1. Most children do not require hospitalization for the treatment of bronchiolitis. Hydration and supplemental oxygen is the guideline recommended therapy for hypoxia. At this time, there is no antivirals with approved efficacy for the treatment of RSV. Various pharmacological treatments have been studied, but there is no evidence that supports their use. So, to conclude, I just want to leave you with a few takeaway points. RSV infections cause significant morbidity in select high risk groups. There is no antiviral for the treatment of RSV. Prevention is the mainstay of therapy, which is why hygiene in the NICU and around all babies is so important. There is no vaccine available currently, but this would be a great step forward in the treatment of RSV. Synagis is the only recommended prophylaxis therapy at this time. And that concludes my talk about RSV.